I'm Bob Williamson, a medical science liaison with Baxter's Worldwide Medical. My role is devoted to the engagement, evidence generation, and scientific exchange of information related to safe patient handling and movement. A principal goal is the reduction of harm to caregivers related to lifting and moving patients. I have the privilege of facilitating 3 outstanding webinars over the course of the next 6 weeks, all of which are devoted to the biomechanics of patient handling and lifting. Today, our focus will be on bed to chair transfers. Manual patient transfers are physically demanding. They're a significant contributor of temporary and permanent harm. Our presentation today will quantify the physical demands of a simple bed to wheelchair transfer. And in doing so, we'll examine the biomechanics behind estimating the demands and ultimately demonstrate the importance of using mechanical lifts. Our presentation today will be led by my colleague, Dr. Jacob Banks. Dr. Banks is the principal engineer in the Baxter Ergonomics Laboratory. His research has focused on applying musculoskeletal models to estimate injury risk and improve healthcare product design. He earned his PhD in kinesiology from the University of Massachusetts Amherst. He trained as a postdoctoral research fellow at Beth Israel Deaconess Medical Center and Harvard Medical School. He worked as a research assistant at the former Liberty Mutual Research Institute for Safety, and he's published and presented his work in over 50 international biomechanics and ergonomic conferences and peer-reviewed journals. Before we transition to Dr. Banks, I'd like to acknowledge that today's presentation will be recorded and available to download. Additionally, due to the tremendous response and number of participants on today's webinar, our microphones will be muted. Please submit any questions that you have into the chat. We'll address those at the conclusion of Dr. Banks' presentation. And without further ado, I'd like to turn things over to my friend and colleague, Dr. Banks. Jake?
Cool. Yeah, thanks, Bob. Thanks for that introduction. Thank you all for attending our talk today. This is great. I'm excited to be doing this. As Bob just stated, my name is Jake Banks, and I'm a researcher scientist at Baxter International, formerly Hillrom, for some of you maybe less familiar with that. Where's it going here? It was just working a second ago. There we go. As part of being employed by a company, I need to make the disclaimer that some of my work I'll be presenting today was funded by Baxter. It's a publicly traded company for profit, which as of 2 years from now, as I just said, owns Hillrom and Lico products as well. However, the opinions today are mine alone and not of the stakeholders. With that out of the way, let's get started. As most of you are probably aware, healthcare workers are amongst the most injured occupations. According to the U.S. Bureau of Labor Statistics, healthcare and social assistance workers have the highest number of days away from work due to musculoskeletal disorders, even above those in sectors like construction and manufacturing and mining. And this data does not even consider the large number of self-diagnosed or unclaimed injuries which presumably occur in the healthcare field. Further, it does not include the roughly 15% of all healthcare workers who will leave the healthcare field because of their chronic pain. And this is a lot more than just a number or a rank. The financial and societal burden of these musculoskeletal disorders on the healthcare profession tends to be even more compounded than other job sectors because their essential contribution to all of our well-being and the general difficulty in filling these positions. Musculoskeletal disorders can occur to most any area of the body, but in healthcare workers, injuries to the lower back result in the most lost days away from work from musculoskeletal disorders. For example, the BLS reported that over 50% of all days away from work from musculoskeletal disorders in nurses occurred to their lower back. This is opposed to other bodily areas like the legs, arms, or shoulder injuries, which are also obviously get injured. This percentage of claimed musculoskeletal lower back pain injury is at a higher rate than any other profession and well above the national average of 40%. Further, roughly 65% of all nurses will experience lower back pain in their lifetime. This is also, again, well above the general average of about 42%. Lower back pain is so prevalent in healthcare workers that many of them are just of the unfortunate opinion that back pain is an inevitable part of their job, which is quite remarkable and troubling. So why are those in the healthcare field susceptible to lower back pain? There are three risk factor categories that are associated with lower back pain. Psychosocial risk factors include things like the work environment, job control, and stress. Personal risk factors like gender, age, history of injury, and personal habits also are risk factors for back injury or back pain. In the third risk factor, biomechanics, this comprises of the task-related demands or job-related demands like exertion level, vibration, task frequency, the job duration, and the postures that you're in. It's pretty easy to find elements of all these risk factors that is associated with healthcare workers and the demands of the job. And that isn't good, as these factors can compound one another and build off of it and make it really increase your odds of getting back pain if you have a lot of these things going on. As such, all warrant a discussion in ergonomic considerations. However, I'm not qualified to get any further into psychosocial or personal factors associated with lower back pain. If this is something you're interested in, we should talk about getting that organized. However, given my research specialty in biomechanics, I feel comfortable presenting about lower back pain from a biomechanist point of view. So this talk will focus on the biomechanical demands of the job and what it can tell about lower back pain risk for those in the healthcare field. To begin, just let's get started with a little basic anatomy so we're all on the same page. When talking about back pain and injury, ergonomists are generally concerned about the L5-S1 joint. The L5 refers to the fifth vertebrae, the lumbar region, the farthest down there. S1 refers to the first sacral vertebrae. The joint is essentially the disc between them that allows the movement in all directions. This joint is restricted by things like ligaments, muscles, and vertebral facets. This location of interest, way down on the spine, its inferior, because of its location way down the spine, lends to a high internal forces, and not so coincidentally is the site of the highest percentage of back pain where most injuries occur. Injuries like in-plate fractures, disc herniations, and nerve root irritations occur to this area. These injuries are often associated with high compressive forces, making L5-1 joint compressive force a good surrogate for back injury risk because it is sensitive to task demands and is a logical pathway for injury. The L5-S1 compressive force is also emblematic of demands across other areas of the back. So knowing what is going on here also provides an estimate of injury risk in other areas as well, not just the L5-S1. And for clarity, the L5-S1 joint compression is the compressive force between the L5 and the S1 vertebrae. So it's the sandwiching, compression is the inward compacting force of the two vertebrae pushing on that disc and opposing one another. In the spine, it causes two vertebrae to sandwich the disc, as seen here, pushing inward with the blue arrows. High compressive force at the disc or joint as will occur because the entire spine is a class 1 lever system. Or, if you remember from your physics, it's a seesaw. Or since I'm from the Midwest, I'd call it a teeter-totter, but I don't know if everybody would know what that means. But it's a class 1 lever. You have two opposing forces, as you see here with this cartoon. They're trying to rotate about a fulcrum or the joint. These forces can rotate the joint against one another by either changing their magnitude or the distance between the joint, as the force persists, whatever it is. In the spine, our muscles are at an unfortunate, unfavorable disadvantage from the joint center. Around, let's say, 2 inches from the joint center, they stick out. And this is pretty much a constant number. So to balance out the larger external forces that are being applied much further distance away, the muscle force needs to be at a much higher force than what it's being lifted. This is what is being represented in this cartoon here of the child being what maybe something is being lifted, say a box, and the muscle force would have to be something proportionally big like an adult closer to the teeter-totter pivot point. The combined force of these two things all pushing downward on the fulcrum, that triangle right there, and including the trunk mass and other masses above that point, leads to compressive force at the joint in the vertebrae. And as you'll soon see, this leads to a much higher force on the spine than what you would initially assume. But how much force is injurious, and just what kind of force are we talking about here? And what is considered high? The National Institute of Occupational Safety and Health, or NIOSH, in collaboration with many world experts, set a standard over 30 years ago for back injuries that has proven to be beneficial to this day. They found that jobs that have tasks that exceed 3,400 newtons, or roughly 750 pounds, of peak compressive force are more at risk of injury. The 3,400 Newton compressive force standard is based on biomechanical, physiological, and psychophysical research for risk of chronic injury, where over time, this level of force on the lower back joint in the surrounding tissue will wear down the tissue, if not provide enough time to recovery, lowering the margin of safety between the load and the injury threshold. This is how a task can be acutely safe but become injurious over time. So do healthcare workers exceed this limit with some of their tasks? 750 pounds seems relatively high, right? So a healthcare worker doesn't weigh 750 pounds, nor usually should the patient they're lifting weigh that much. So of course they do, right? I wouldn't be here talking about this. This wouldn't be much of a series on talks if everything you did was safe here. So there are many daily activities associated with healthcare workers that have high demands, which exceed this 3,400 Newton threshold. For my talk today, I'm going to focus on bed-to-chair transfers. A bed-to-chair transfer or wheelchair transfer are transfers that involve the healthcare worker taking hold of the patient, whom would be seated on the side of the bed, and physically assisting or lifting the patient to the wheelchair nearby, as seen here. This simple and essential common transfer can be a demanding task. Here I've plotted the range of estimated in vivo compression demands on the lower back from a few different studies reporting the estimated demands of the lower back for one-person manual transfers from the bed to a chair or a wheelchair. You'll see that most transfers exceed 3,400 newtons as depicted by the red dotted line. You can see a decent amount of variation between these studies, which I'll get into later in my talk and maybe hopefully show you where that might come from, and how these forces are estimated. I'll also get into how they're estimated. But the basic component of this slide is that this task is very demanding and can exceed suggested standards. And the high demands associated with lower back pain in healthcare workers from patient handling and mobilization is unfortunate because patient mobility is essential. Evidence suggests that patient mobility, mobilization decreases the length of stay, relieves pain, reduces thrombosis, improves physical stamina, and reduces the likelihood of getting pneumonia and many other hospital-associated infections. So, what can be done to make this essential transfer safer? Do ergonomics interventions exist? And again, the answer is yes, they do. One common and very inexpensive device to aid manual transfers is a slide board. A slide board is a simple, low-cost intervention aimed at reducing vertical demands against gravity during manual transfers. It allows the healthcare worker to slide the patient, use a bit of gravity in the process, and avoid lifting them altogether. But do these actually help reduce lower back demands in dependent patients? The answer here is we don't really know yet. This is a research gap regarding one-person transfers from the bed to a wheelchair or chair. A direct comparison between in vivo lower back loads using a gait belt and a gait belt with a slide board during manual transfers has not been presented. Previous work has primarily just documented the in vivo forces for manual one or two-person transfers. It is unknown to what extent slide boards may help. Do they actually reduce the in vivo demands, or do they just encourage healthcare workers into manually performing a task they shouldn't? So to state this more scientifically, the aim of this work is to quantify and then compare lower back demands during one healthcare worker transfers from the bed to a wheelchair with and without a slide board. And we will record and compare perceived exertion levels along the way as well. We hypothesize the slide board will reduce physical demands on the lower back, but the perceived and estimated demands will still exceed ergonomic standards. We went about answering this question with a lab-based experiment conducted at our facility in Batesville, Indiana, the former home of Hillrom. We recorded and consented 13 active healthcare workers from that Southeast Indiana, Cincinnati area. The participants were required to currently be employed in a job that requires daily patient transfers. For numerous reasons, the patient, though, was a healthy, around a 64 kilogram male who was a member of the research team. He was instructed to act dependent during all transfers. He did, however, maintain trunk support and his feet could touch the floor, but he did not insist in any other way. As pictured here, the transfers were from a hospital bed to a wheelchair located nearby. The wheelchair was in the locked position and had the right closest armrest removed. The bed height was adjusted by the healthcare worker to what they preferred or perceived to be the best height for them. During each transfer, a healthcare worker used a gait belt or a gait belt with the standard wooden slide board. We did not provide any instructions on how they should transfer the patient because they knew probably better than we did. All transfers were performed for 3 repetitions and went from the healthcare worker's left to their right. The kinematics of the healthcare worker were recorded with a full body marker-based motion capture system. You've seen here with the silver dots. We'll show you in a minute what this actually looks like. This is the same technology they use for making movies. Additionally, hand forces were directly recorded via custom gait belt. The gait belt was modified with load cells placed in series of cloth handles as seen here. Motion capture markers were defined the location and orientation of those hand forces so we could use them in our model. In the healthcare worker, we're always required to use those handles. Worth noting, the direct recording of these hand forces is also a novel part of this experiment that has not been used before to quantify demands. So our two dependent variables of interest today were the perceived level exertion and the peak L5S1 compression force. Perceived exertion was subjectively measured by verbally just asking each participant to rate their exertion level on a 0 to 10 modified Borg scale, with 0 being the lowest level of exertion and 10 being the highest level. Participants were asked this after all 3 repetitions of a given transfer were performed. This was admittedly more of a secondary measure used to gauge what the healthcare workers felt about the task. It was not necessarily the focus, and this was not necessarily focused about back demands, but just their overall level of perceived exertion. Our primary measure of interest was peak or 95th percentile L5S1 compression. But how do we get this measure, right? You maybe have heard this before. And how is this actually measured from a recording like this? How do we get this peak L5S1 joint compression? If you're thinking that, I'm very glad you're asked, because I'll get in that here right now. Unfortunately, in vivo L5S1 joint force is not readily determined. One means is a direct method. The direct method of estimating internal loading uses either highly invasive and challenging methods involving directly measuring from either intervertebral pressure or forces with an instrumented vertebral implant. Even after all that, these directly measured in vivo forces still only reflect a portion of the loading and are clearly limited. And for better or worse, we just can't go around inserting pressure transducers in discs or do a full body vertebral body replacement on our participants. Those that have done this, there are some reports of this being done, were either conducted on members of the research team or in patients who were candidates for vertebral implants without much else to lose. So this really is not an option for us or for most other laboratories. Alternatively, when your participants and even more likely your institutional board won't allow for those invasive techniques, you can use musculoskeletal computer models of the spine using observed human movements, rigid body dynamics, detailed dissections, and a wee bit of additional math, which I'll get into. This is like the calculations engineers perform when looking at like bridges or trusses and things in structures, where you can't directly measure it and cut things apart, but you can do it with some math. While it's not without its own faults, unlike direct in vivo measurements, these computer models, once properly evaluated for accuracy, can safely estimate forces from everyone, not just those gullible enough to have the pressure transducer inserted or someone who is a candidate for vertebral implant. Models can also be readily applied for most any task and simultaneously across any level of your back you wish to quantify, not just where that is implanted or where you put the pressure transducer. So now we're going to get into briefly how this is done. We start with a generic base mathematical model seen here. This is a musculoskeletal model or a computer model. It really only exists virtually as a set of equations in a computer program. Such models can account for gender, limb lengths, muscle sizes, and masses. So then we take some participant-specific information to make these models, fit the participant. This information includes the calibration. We have all these markers on them that we can get the segment lengths and their heights from that. And so we can better match that model to the individual. In addition, we adjust the mass of this model to just simple body mass so that all the limbs and things sum up to equal the same amount that they would in real life. This then produces a participant-specific model made for every participant that you want to study their lower back forces or a particular force in. Now that we have models that represent each of our participants, we want to use these models to quantify what the participants are doing during a given task, or in our patient transfer. So here we, again, use the information from the markers of our motion capture, but this time it's not the static pose, it's the actual task that they're performing. Each marker represents a three-dimensional location in space for a given body location. We mathematically best fit the model to fit where those markers are positioned in space, theoretically making the model move. So you see here on the right, these should be the same tasks, even though they're not completely time synced. This process is called inverse kinematics. It results in a tracking solution where all the degrees of freedom, particularly the joint angles, are determined. This is where one could just simply calculate things like back angles and knee angles if we wanted to. So this stuff I think is pretty cool, and this is what I got my doctorate in. But we aren't done yet. So on the left, we have that inverse kinematic solution I just showed you, or the movement. We still need to determine what is responsible for the movement. So, and that's what we call the kinetics. And more specifically, that means the joint forces involved. For each frame of data, we apply Newton-Euler equations of motion to determine what joint forces are responsible for moving the segments in the way that we are observing. The equations of motions are from Newton's second law, the F equals ma, which you've probably heard of if not used, and then the rotational Euler equivalent of the below there, tau equals I alpha type stuff. Using the motion, we use the motion to find the acceleration, so the A in the F equals ma equation and the alpha in the rotational equivalent, which is the acceleration is just the second derivative of all those motion positions we see there. So it's a lot of derivatives, a lot of matrix math involved in algebra here to solve for unknowns. So if you see these two equations and they make you a little bit queasy or give you nightmares from undergraduate math, I apologize, but I hate to tell you this is all a gross simplification of what really is going on. There is more than just two equations and a handful of unknowns. The system is actually mathematically indeterminate, and the tau only represents the total sum muscle forces, not the actual individual muscle forces that move each segment. So we do not have torque motors in our bodies like this. If you recall from the teeter-totter slide, it's a muscle pulling linearly to create a rotation that are at a set distance. So to accurately model the joint forces necessary, we need to know what each muscle is contributing to the torque. Therefore, to estimate the forces of the individual muscles, biomechanists rely on assumptions to optimize the unknown values according to some standard. A well-accepted standard is that the muscles contribute to the joint moment based on their potential to produce torque about a joint. So in other words, for those muscles that can do more, will do more versus their smaller counterparts. When we have all these forces acting at about a given joint, including the inertia and the inertial stuff, the muscle and the external forces, we sum them all together and get them all compiled in these equations and find and solve for the compressive force, which is represented by just one of the many F's in this Fn equation right here in the middle. So after that little tangent, I find it necessary to remind us all of what we're actually looking for here again with our back forces. We are comparing perceived exertion in L5S1 peak compressive force that we estimate from the two different bed to wheelchair transfer conditions with and without the slide board. And we're looking at how those conditions differ from one another and if they're dangerous or risk of injury. So what did we find? Here we have a bar graph of the results of the average levels of perceived exertion across the two tasks. Data whiskers represent the standard deviation, and the open circles individual data points. The slide bar task is depicted on your right and the gait belt alone on the left. There were differences between the perceived exertion levels with and without the slide board. The gait belt alone Transferring the patient without assistance of the slide board perceived to be more demanding than the slide board condition. Still, the gait belt only transfer was perceived as mostly easy most of the time, and at worst, the worst any one of the participants rated it was hard. And the slide board was pretty similar, even though it was statistically different. Now, what did we find with our estimated L5S1 joint compression? As with perceived exertion, compressive forces were different, with, again, the gait belt only transfer having higher demands than when performed with a slide board. So the slide board seems to help reduce things statistically. But while neither of the group averages were above it, compressive forces still frequently exceeded the NIOSH suggested load limit of 3,400 newtons during individual trials, even with the slide board. So these forces could still be quite hard during this task of this relatively light patient. Let you look at that for a second while I get a drink here. So again, the slide board seemed to help, but they're still pretty high forces. Anecdotally, it's worth knowing that the peak compression tend to occur more at the lateral end of the transfer, when the healthcare worker was setting the patient into the wheelchair, particularly during the gait belt only trials. We'll see here in this time series of the overall compressive force. At initiation, you see the force is quite low and driven solely by the posture and the body mass of the healthcare worker. And there's no load in the hands here. As the healthcare worker lifts the patient, the compression force increases due to the increased load in the hands. Then while the healthcare worker is moving towards the chair with the patient, they reach kind of a peak standing height. This is not necessarily the instant of greatest force, though, as the posture is pretty decent, and perhaps some of the patient weight is probably touching the floor with their feet, or they are in the process of lowering the patient, so the acceleration, they're not fighting gravity as much. But as the healthcare worker is placing the patient into the chair, the healthcare worker is compromised posturally because it's kind of he or she is reaching over towards the chair to guide the patient into place while slowing the patient's acceleration for a safe and comfortable landing. This is where we saw most instances of peak compressive forces, but not all. And this is all just happens, obviously, then they release the patient there at the end and the hand forces go down, and so too do the compressive forces. And again, this is mostly with I'm representing here the gait belt only condition. So those were our forces. And as far as the validity of our measures, it's good practice to go compare one's work with the previous equivalents, given the amount of math involved. There's things that could go wrong. Our estimates were pretty well in line with what previous work had showed. I'll remind you that these are all non-slide board trials that were done before because they hadn't really compared one-person slide board conditions before. You'll see that our estimates are within the ballpark of these prior estimates. Of course, there's a lot of variables that differ between work. Notably, different work will have different patient sizes and dependencies available. Obviously, heavier and more dependent patients will result in higher forces. There's also differences between these studies and modeling approaches. I showed you how I did it. There's other ways of doing this, including how they estimate the hand forces rather than measure them directly, and whether the assumptions used to estimate the muscle forces involved. Like some research groups will use EMG and things to help estimate forces not using optimization. And also, while it has been directly examined in the context of patient handling, work and materials handling has shown that skilled and experienced workers seem to develop techniques that may help reduce lower back loading. We had experienced healthcare workers. Some of these studies may have had less experience, or college students moving patients, so that could have impacted their results. But despite this variation between and within studies, there's relatively strong agreement with our work and the previous that we have some confidence in our measures. Of course, there are other limitations, most notably as I just kind of alluded to, the estimates of loading from musculoskeletal model. All of the limitations which come with such models can be assumed, and I'm happy to get into more of those in more detail if people have questions about those. But the models obviously aren't perfect. In terms of perceived exertion is a very inconsistent, it's been shown to be very inconsistent both within and between participants. So those measures need to be taken with a grain of salt. but they are still interesting. And then in our transfer task, we had a gait belt with handles on it. Handles may not be on all gait belts, and the handles may have provided be a different posture than what you would if you just had a standard gait belt. And it also may have kept them from using the preferred technique, which would result in different demands. We did record the hand forces directly, which is one of the best methods to doing this, obviously, but there could have been some error in recording those hand forces if not all the forces were transferred within the hands. But if that were the case, at the very least, this is an underestimate of forces, not an overestimate, if we weren't recording all the hand forces. Also, as alluded to, the patient was only acting dependent, so there was some subjectivity there. However, we feel any unintended assistance is probably outweighed by the fact that he was most likely smaller than a typical patient and also did not have any IVs or O2 lines, catheters, or other health concerns that would adversely impact the transfer. While all transfers are unique, this transfer could probably be viewed as a best case scenario, and it still at times would exceed ergonomic guidelines, even with the slide board. But a slide board would have other places where it may be more beneficial if the patient were somewhat dependent with their upper body, and then the patient could use the slide board without the assistance of the healthcare worker to slide themselves down. But that's kind of an entirely different story. We also only studied here one-person manual transfers. There are other techniques or transfers and interventions that can impact the design or impact the demands, and I'll show you those in a second here. And then finally, the scope of this talk was lower back pain or injury risk. So we're assuming that the lower back is the weakest link during this task, which may not have been. Maybe the shoulder, we're looking at the forces in the lower back, but maybe during this specific task, the shoulders were at higher risk of injury than the lower back. So again, this is making this task probably a best case scenario. So what does this actually mean? While slide boards seem to sort of help, they are not really a game changer for dependent patients. They definitely reduce the perceived effort, but they may not be a good thing given trials still can exceed ergonomic standards. So just because it helps a little bit, it still might not help enough. So what could we possibly do here to help move this patient? Well, there are options. There are other options, right? And a mechanical, mobile, or ceiling lift can be performed the physical demanding part of this task for us and really help reduce the demands. And this has been shown with biomechanical models. Researchers have shown that lift equipment drastically reduces forces, both mobile and ceiling lifts. Compressive force magnitudes fall way below the recommended guidelines here. So you have to look way up on the top right of this to see where the NIOSH limit is relative to the forces that they've recorded or estimated when using lifts. And while there are, of course, we know that lifts come with financial investment, they can pay for themselves. It's been shown that they can pay for themselves through injury reductions and workers' comp claims. So healthcare workers can transfer patients safely. But of course, some of you may still be saying, but why not just get someone else to help me? Manually lift with two people, I can cut my forces in half. You would be correct in thinking that the physical demands, particularly the L5S1 compression, will be reduced with two people, but probably not to the level that we would think. That's because the external load isn't the only driving thing in the demands. The load may be cut in half, but not the demand on the lower back. Because while you're cutting the load, you also seem to be doing so with compromises in posture, and you're also still fighting your own body weight when doing a two-person transfer, and you're in a very awkward position. So that's what was shown here, that while two-person lifts can reduce compressive force, they don't just cut it in half. And now, an observant audience member may look at the graph that I'm showing you here and find the magnitudes that predicted be way higher than the ones I just showed you. And that's because the aforementioned different modeling techniques. They used an EMG-driven model in this study to compare one and two-person lifts, and those are a little bit more sensitive to these high demands like this. They also didn't have a gait belt, so you can see that they're reaching out further than maybe our participants were, and that would, of course, negatively impact postures. So I'm not really showing you this graph to just really get into the actual magnitude, but maybe the relationship between one and two-person lifts. Also, this is just one type of transfer for patient mobilization. The type used on patient is the type of transfer used on a patient is largely dependent on the mobility and the goals of that patient or their healthcare provider. But for the sake of time, other transfers have been shown to have been modeled equivalently and shown to have similarly high loads. And as far as repositioning in bed, my colleague Neil Wigerman in the second part of this biomechanics series in 2 weeks will go over some of the demands of additional considerations for repositioning in bed. So that's something you should put on your calendar. But perhaps some of you are still wondering 3,400 newtons is for chronic, but how high is really high? So this is just something anecdotally that I like to always show people. It's something kind of interesting, especially considering we're in the midst of Olympics here. They have modeled deadlifters using similar modeling techniques that I just showed you. And they estimate that during the Olympic deadlifts of, 700 pounds or whatever they're deadlifting here, that deadlifter, when you model them using this technique, can reach compressive forces of over 20,000 newtons. So that's pretty substantial. I forget what that is. It's like 2 tons. So, but please don't, read any more to this other than appreciate what steroids can do for you, I guess. And that also, I think we can assume that these people at some point in their life have back pain as well. And they're also highly trained and have the perfect amount like rest time in between. So after all that, what can we take away from today's talk again? In summary, perceived and estimated force demands across the 2 transfers differed. And in support of our original hypothesis, the gate belt trials were more demanding than when slide board was used. But even the slide board transfer conditions still had individual trials that exceeded the suggested ergonomic limit for compression force due to the high loads involved in the postures. And this did not align with the perceived exertion level. Our healthcare workers still at worst rated this task as being somewhat hard, showing that healthcare workers are accustomed to doing very demanding tasks and have a high standard for what is demanding. And that's for better and probably more likely the worse for their injury risk. Also, I must keep harping on the point that we modeled a best case scenario. This patient was 150 pounds, wasn't combative or unpredictable, didn't have IV lines, and was not fragile. So, he wasn't fragile, so you weren't worried about setting him down. And still, this patient, in quite a few instances, had the healthcare worker exceeding established ergonomic guidelines. And ultimately, the safest means for performing any of these transfers is to just use mechanical lifts whenever possible. It reduces it cuts these loads by, I believe, like at least 60%, and it makes it more secure for the patient, it's shown, and it reduces injury risk. And then finally, along the way, I hope you gain some appreciation for how these physical demands are estimated and used to determine injury risk, and that, math is sort of fun here. So finished a little bit ahead of time, but that gives us more time for questions. In the meantime, for those of you who want some more detail on this is most of this research is published. We published this 2 months ago in the Journal of Industrial Ergonomics, my colleagues and I. And also a reminder here, I believe they put it in the chat, links for the other talks coming up later this month. So thank you.